Well, thank you. I'm not exactly a stranger to this hospital. Someone tracked my history down of last being here in 1981, and before that in 1977, and I'm sure it all dates back to somewhere in the 1960s if the archives were that old. So it's kind of a homecoming after a perhaps longer lapse than usual. The topic I've chosen today is one that is very important, but one in which I don't think I can give you a whole lot of enlightenment. One of the problems is that we simply have run into a blind wall as far as developing any new drugs. When I began to use chlorpromazine in 1954, I assumed that sometime in the future, like 30 more years away, we would have drugs that would be much better than chlorpromazine, have fewer side effects, and really be much more specific in treating schizophrenics. We also had the hopes that we would have a much greater knowledge about the fundamental biology of schizophrenia. But surprisingly, in the 30-some years since then, it's been somewhat disappointing that we really don't have any drugs that are any better overall. In fact, it's been extraordinarily difficult to show that any of the peer antipsychotic drugs are better in a group of patients than any others. We do have some drugs that are more specific in their actions, have fewer unwanted pharmacological effects, and produce on fewer side effects. So that many of the newer drugs, particularly the high-potency drugs like fluphenazine, Prolixin, thiopixine, Navaine, or haloperidol, Haldol, are now preferred over some of the low-potency drugs such as either chlorpromazine or thioridazine Mellaril. But in terms of what we can do for patients, we haven't increased our abilities all that much. I think also we have a great deal more knowledge about schizophrenia, but nobody has yet been able to synthesize it into any coherent framework that allows us to get any idea of how to treat our patients better. And even as I survey the current attempts to develop new treatments, they all seem fundamentally to get back to the same general mechanisms of action that our older drugs had. So at best we may get some technical advantages in having drugs that may be more specific in their effects, say, on dopamine systems, but not necessarily more effective overall. If our drugs were really good, we shouldn't have so many patients who might be construed as treatment resistant. I don't know how many such patients there are, but I know that a new drug is coming along soon that is directed at treating treatment-resistant patients or those with tardive dyskinesia. And when I heard about these two indications, I said, what else is there? You know, it really pretty much comes down to that. So there are a lot of these patients out there. Now, we obviously don't see them in the hospitals because for a variety of reasons, the inpatient treatment of schizophrenia has decreased markedly over the last 25 years, to where most inpatients now represent only about 10% of what used to be the case. But still, we have these patients out in the community who still are far from being very functional. In fact, I have great difficulty in understanding some of these follow-up studies that say that so many schizophrenics do so well. That certainly doesn't seem to be my experience. But in any case, we have a lot of patients for whom we could do better. And what do you do if you have a patient who hasn't responded? Well, I like to think of 4 Ds, and that is diagnosis, drug, dose of drug, and considering a different treatment. Just having the D's to make it easier on my aging memory. But I think they have some importance practical. For instance, the diagnosis of schizophrenia is still essentially a clinical diagnosis. And since there are no pathognomonic signs in psychiatry, nothing in psychiatry, no symptom or sign that is specifically associated with a particular illness, we have to view the constellation of symptoms and signs and try to make a diagnosis. And that's tough. We're way behind the other branches of medicine in being precise about diagnosis. Now, there's some things, though, that can confuse you. Psychotic depressions may often look like they're purely schizophrenia, when in fact they have a high component of depression. The same thing can be true of schizoaffective states, where the psychotic elements override the affective disorder. Now, both of these kinds of patients may do very well by the addition of an antidepressant drug. So that I think we always have to think when some of our patients don't come around, is there a depression or an element of depression that we may have missed? Conversely, it's often very difficult to distinguish between mania and schizophrenia. The older literature had an abundance of articles saying that if you followed a patient with manic depressive disorder long enough, they would eventually wind up with a diagnosis of paranoid schizophrenia. Today, that has been turned around 180 degrees, and most people are of the opinion that if you follow paranoid schizophrenics long enough, they might wind up with a diagnosis of mania. I guess this is because we think we can treat mania now somewhat better than we could some years back. But in any case, there's a tremendous overlap between the manifestations of mania and paranoid schizophrenia. So it may very well be that some patients currently labeled as paranoid schizophrenia have mania instead. Well, antipsychotic drugs are perfectly okay for mania, but they may not be enough. And this may explain some of the instances in which the addition of lithium or carbamazepine, Tegretol, to an antipsychotic drug may change the course for the better. And then perhaps a less likely area of confusion are patients who may have what would be construed as chronic delirium, either because they're taking some drug that produces it or they have some intercurrent medical illness, who are often misdiagnosed as schizophrenia, when indeed they really don't have the typical clinical manifestation. However, I think any good clinician really ought to be able to tell the difference between chronic delirium and schizophrenia. Nonetheless, diagnosis, which is so very primitive in psychiatry, is still very important. And since it's largely clinical, it means that we have to use our clinical skills in the best way we can. Yep. How do I go backward? I don't seem to have control up here. Now let's try to there. Now, one of the problems also is that schizophrenia itself may not be a single entity. Of course, this is an old debate. Is schizophrenia the same sort of designation as maybe Bright's disease was 100 years ago, that encompassed all kinds of kidney disease? Or as anemia might have been early in this century, where now we can parcel it out to a dozen or more different kinds of anemias that are sometimes very specific in their etiology. Does schizophrenia is it more of a syndrome than it is a particular disorder or illness? Well, these debates go on, and currently the feeling is that perhaps there are two schizophrenias, and that this may explain some of the refractoriness we might have to drugs. I've never had such trouble as I seem to have. Now, this is not a new idea. There's an older literature that has a lot of dichotomous terms for schizophrenia. In Europe, for instance, this term has been used a lot, true versus schizophreniform psychosis. And true schizophrenia in this definition is a insidious onset, very chronic, deteriorating course, whereas schizophreniform disorder is construed as a relatively rapid onset in somebody with a good premorbid history and usually a self-limiting course that may reconstitute entirely or at least show enough improvement that the patient functions even though they have moderate degrees of impairment. And these other terms mean essentially the same thing, good prognosis versus bad prognosis. Back in the 1940s, the psychologists at our hospital came up with a terminology reactive versus process, and so on. So it's long been evident that schizophrenia may have different modes of onset and different natural histories that suggest there may be more than one kind. And indeed, right now, there's a great deal of emphasis on trying to develop evidence for the heterogeneity of schizophrenia. However, in the last 10 years or so, two new terms have been described, one called functional schizophrenia and the other organic. Well, there we go. Now, the basis for this division came about 10 years ago when Crow's group in England did the first CAT scans on schizophrenics and found that some of them have ventricular dilatation. This finding has been repeatedly confirmed over the years. There have been a few negative studies, including one at my former hospital, but in general there seems to be a fair amount of evidence to suggest that the brain may show some atrophy. The big problem is every paper reports it in a different place, and that's somewhat confusing. But based on that, Crow hypothesized that patients who have this morphological change in their brain may indeed represent a true dementia precox. That is, they have an organic brain disease. And those who do not may have a disturbance in dopaminergic neurotransmission, which is remediable by antipsychotic drugs. Well, the idea of this change has been looked at in many different ways, and for instance, one of the current findings is evidence of decreased glucose uptake, primarily in the frontal lobes of schizophrenics. Whether this is the cause or the effect of some atrophy there is uncertain. I must admit that I've had trouble with this brain atrophy concept. For years, neuropathologists have had the brains of schizophrenics in their hands on the scale, on the cutting table, and under the microscope. And they've come up with virtually no evidence of any specific morphological lesion that's associated with schizophrenia. And I can't imagine that they all fail to observe significant brain atrophy. After all, if you can measure, if you can weigh the damn brain, why should you miss it? So I don't know what to make of this. Why is it that this image that we get on a computerized tomographic scan will pick it up when you can't pick it up when you have the brain in your hand? Be that as it may, it's an interesting concept that, and here's you can't see it very well on the slide, and some scans showing the presumed atrophy. It's kind of marginal at best, but it may be there. And this shows the hypofrontality that the schizophrenics have on a PET scan, showing some decreased glucose uptake and decreased cerebral blood flow. Could these manifestations be secondary to disease rather than primary? An interesting piece of work that people seem to have forgotten was done many years ago by a couple of experimental psychologists in Berkeley who took rats and put them either in a very enriched environment or a very impoverished environment, And then after several months, which is a fairly sizable part of the rat's lifespan, killed them, took out their brains, weighed the brains, and assayed by the crude assays they had of those days for acetylcholine activity. And oddly enough, the rats in the impoverished environment had not only decreased brain weights, but decreased acetylcholine as measured by a bioassay. As I say, this work has been largely forgotten, but it does suggest that perhaps the withdrawal that schizophrenics show may account for the deteriorating course that used to be so typical of them many years ago. And perhaps it accounts for these changes both in decreased blood flow to the forebrain as well as the various kinds of atrophy that have been described. Interesting idea, should be checked out. I don't know why somebody isn't doing it. Well, the upshot of this, though, is that it's a very discouraging picture. That is, we have two kinds of schizophrenia. The functional type is presumed to represent an abnormality of dopaminergic neurotransmission, to be manifested by positive symptoms, mainly those connected with a disturbed thought disorder, responsive to antipsychotic drugs with normal CT scans. And at the moment, this seems to be the majority of schizophrenics. But that there is another group that's organic, again in quotation marks, that are characterized primarily by negative symptoms. That is mainly social withdrawal, a poor response to drugs, brain atrophy on CT scans, and a cause that is still highly speculated. Crow thinks it may be a virus. Other people have been, implicated a whole variety of possible insults to the brain. However, as I said, over the years, neuropathologists have not been able to find this. Usually when you have brain atrophy, you show some residuals of it, increased microglia or something that would indicate that neurons have been replaced. But this has been very hard to find in schizophrenia. If this is true, however, this may be the solution to our problem of why some patients don't respond. The only problem, difficulty with it is while we may have a solution, it seems to be a rather hopeless idea that we, with any currently available drugs, we can budge these people at all. And that to me is a little bit too discouraging to accept, although I have to entertain the notion. I'm not emotionally able to take it on at the moment. Maybe that's a form of denial, but in any case, I'm going to still be hopeful. But this could be a possible explanation. Now, let's go on to drugs. As far as we know, every antipsychotic drug that we have works fundamentally by blocking postsynaptic dopamine receptors. This is a schematic drawing of a dopaminergic synapse with a presynaptic nerve ending. The vesicles contain the neurotransmitter. When the nerve fires, the vesicles migrate to the surface, discharge the neurotransmitter into the synapse, and eventually it reaches a postsynaptic receptor and neurotransmission goes from one neuron to another. Of course, this is vastly oversimplified. You're talking about a stochastic process in which there are literally thousands, if not millions, of these things going on at once, and it's the additive process that makes the neuron either go or not go. Now, our drugs, as we currently envision them, block these postsynaptic receptors and decrease dopaminergic activity downstream. When this occurs in a portion of the brain called the mesolimbic system, which begins in the midbrain, goes up to the limbic system, and then up to the frontal lobes, we think we get the antipsychotic effects. When you block the same receptors in an older pathway that has been known for much longer than the mesolimbic, that is the nigrostriatal pathway, we get the Parkinson's syndrome. That is the ability of the drugs to produce a condition that mimics naturally occurring Parkinson's disease. Well, this is the one we want, that's the one we don't want, but we have stupid drugs, unlike these smart bombs that the military has that go right to their targets. Our drugs are stupid, and they go to the system we don't want to budge, as well as the one we do. And both of these are novel pharmacological effects that are only known for antipsychotic drugs, never known before. So these are unusual in that respect. Well, if all the drugs then work through this fundamental mechanism, there may not be so many great differences among them, but there are a great variety of drugs. In fact, this is a rather curtailed list, but in general, one can think of them as high-potency, low-dose drugs in which the daily oral doses are measured, say, in tens of milligrams a day, or low-potency, high-dose drugs where the daily dose is measured usually in hundreds of milligrams a day. And these are three examples of the high-potency drugs, two examples of the low-potency drugs, and then a couple of others that are sort of intermediate that are sort of second or third line drugs. Most people these days are moving to the use of these high-potency drugs, whether it be fluphenazine, haloperidol, or thiazide, simply because they have a more specific effect on dopamine systems than they do on, say, blocking alpha-1 adrenergic neurons receptors, or blocking muscarinic acetylcholine receptors, or blocking histamine receptors, all things that may produce unwanted side effects. So you get more antipsychotic action for your money with these drugs with fewer side effects. And indeed, some of us have almost thought that these two drugs might be, if not obsolete, at least used only for specific purposes. Nonetheless, it's been known ever since we had more than one antipsychotic drug, and as luck would have it, we had two simultaneously, both chlorpromazine and reserpine, that patients who don't respond to one may respond to another. The big problem is how to pick them out. Do we know in advance which drug to pick for which patient? Well, I spent a fair amount of my career looking at that problem, and I must say that we struck out. We never really found the secret. You'd find it the first time around, but if you were silly enough to try to replicate your findings, it vanished. So the moral is don't try to replicate. But in any case, we still don't know how to make this choice. Well, one possibility then is that the original drug you chose for your patient may not have been the one to which that patient will respond. But clearly you can't go through all of these, or can you? I see a lot of charts of patients where, by golly, they've gotten all of them. And so it's not impossible that over the years that schizophrenia lasts, that patients will have been tried on many different drugs in the hope that maybe one will be better than the others. And we don't know why this occurs, but I would certainly commend it to your thinking about these patients to look over what they've gotten, try to decide whether they've really been given a fair trial on the drug, one that will either confirm or refute its efficacy, and then make sure you're not missing any bets. I remember not so long ago we had a patient who had rather disturbing voices that were bothering her all the time. Otherwise she functioned pretty well. She had a couple of kids and kept the house together and seemed to be able to hold on to her husband. But she was always troubled by these voices. Well, we tried one drug after another, and I even poisoned her with lithium. We never got to first base on any of them until one of the residents looked her chart over and said, gosh, she's never gotten any chlorpromazine, and put her on a rather small dose of maybe 200 or 300 milligrams. Voices cleared up and she was fine. So, you just have to be sure you're not missing any bets in choosing your drugs. Now, there are some other reasons why patients may not respond to antipsychotic drugs, and there is a possibility that some patients simply metabolize drugs so rapidly that they never develop an effective plasma concentration that exploits their full pharmacological action. The second thing that we've noted is that while dopamine receptor blockade seems to be essential for the action of these drugs, and although studies in animals suggest that relatively small doses of these drugs will block up to 80% of the receptor, this block in man seems to be very tenuous. We ran across this back in the 1960s when we tried levodopa as a treatment for depression, based on the notion that levodopa could be a precursor not only for dopamine but also for norepinephrine. And what we found, much to our surprise and somewhat contrary to what the group at the National Institute of Mental Health found, was that our depressed patients became crazier. This led us to say, well, if everybody then was looking for what could make people crazy, and Seymour Ketty had reported that methionine would do it, but dopa really seemed to be a much better way. So we tried it out in a dozen patients who had schizophrenia, who had been on antipsychotic drugs and had plateaued at a reasonable level of remission. And relatively small doses of levodopa added to this regimen made them worse, aggravated their psychosis. So it suggested that perhaps this blockade of dopamine receptors that was so essential for the for the efficacy of these drugs was very tenuous and could be easily overcome by giving a precursor for dopamine, such as levodopa. Subsequently, we tried apomorphine and had exactly the same experience. Apomorphine, and even in the small doses that are supposed to act only presynaptically, made schizophrenics worse, even though they were under the cover of antipsychotic drugs. So it appears that the action of these drugs is very marginal at best and can be easily overcome. And then finally, of course, there's this question of the organic type of schizophrenia, which, as far as we know, would be totally untreatable by any of our current pharmacological approaches. Well, one of the ways around this has been to say, well, perhaps some patients require higher doses of these drugs than others. And maybe we're under-treating our patients. A very early study was done by the National Institute of Mental Health in which they treated patients with either 300 milligrams a day of chlorpromazine or 2,000 milligrams a day. These were, again, somewhat treatment-resistant patients. And they found that men under the age of 40 seemed to benefit by this high-dose treatment, at least to a significant degree. This was the first clue. Europeans, the minute they got hold of highly specific drugs such as fluphenazine, Prolixin, or haloperidol, began to use monumental doses. Instead of tens of milligrams a day, they were using hundreds. And some of these doses were as much as 1,000 or 1,200 milligrams a day of a drug like Prolixin, which ordinarily you think of in doses of 10 to 30 milligrams a day. Well, at first they reported glowing results, but then as these studies were repeated, they became less impressive. And indeed, some of the latter studies felt that they were actually producing more side effects, and the patients weren't getting any better than they were with smaller doses. It's uncertain as to whether these were truly treatment-resistant patients. They seem to be just any old schizophrenics that come along. Well, we, based on this tenuous block of dopamine receptors that I just described, decided to try this with haloperidol. And what we did was define what we called a treatment-resistant patient. I don't think it matters so much what your definition is, as long as you tell people. There's been a recent study that has had much more rigorous criteria than ours, but at least these were patients who met the criteria, who had at least one prior admission, at least 1 year of illness, and had been on conventional doses, say, of the equivalent of 30 milligrams a day of Haldol, and yet had, or thiazixine, and had not shown any result. This happens to be our second study on thiazixine. They were mostly young men. The majority were ill for more than 2 years, and most of them were very chronic even in their present episode, median hospitalizations of 4 and so on. So they were a reasonably treatment-resistant group. The patients who were started off on more or less conventional doses, although some of them were rather high, and we were uninhibited about how high we went with the doses. Some of them now seem fairly monumental. It took usually a few weeks before we saw the change that we interpreted as an unequivocal response, and the plasma concentrations fell within a range of roughly 20 to 50 some nanograms per mil. But you can see from these brief psychiatric rating scale score changes that they really did show a substantial amount of improvement. Almost all of these had at least a decline in the scores to half of what they were originally, most of them to more than that. And even on the clinical global impression, they moved at least 2 and very often 3 steps on that sort of a categorical scale. So we did find a number of the patients who seemed to respond to this high treatment. We also found some that, whose response was equivocal, and found at least one that showed no response despite a very high dose but a relatively low concentration. So this may be the reason why this patient showed no response. Well, do I recommend it? Even though we've done 2 studies, one with haloperidol and one with thiazide, I can't enthusiastically endorse this approach. First of all, it was safe. Despite these large doses, we didn't see any more side effects than we saw with, would have expected with more conventional doses. But we simply don't know what the long-term implications would be of this kind of exposure if it were for any length of time. But I do believe that if you have a treatment-resistant patient and nothing seems to have worked, it might be well to approach the family and say, look, it may be that this patient is one, albeit of a minority of patients, who may respond to higher doses, and we would like to try that out with your permission to see what will happen. We'll know the results within a few weeks. If it happens, fine. If it doesn't, we don't think anything bad will happen, but sort of get the consent of the people involved before you do it. At least it has some possibility.
Dr. Hollister, what happens when you bring patients down from those high doses after their improvement with the high dose?
They hold their remission for at least a few months after that. And this, of course, has been noted even when you're treating with conventional doses, that once people respond, they don't necessarily deteriorate the day the drug is stopped. It's sort of spread out over a longer period of time. Well, the summary then of these high-dose studies is that there are some treatment-resistant patients who require higher than usual doses, that the plasma concentrations could be more important than the actual dose in determining the response, and that high-potency neuroleptics such as the 3 I mentioned, fluphenazine, thiazide, or haloperidol, are suitable for this kind of study simply because they don't have so many unwanted pharmacological effects. Now, the final D is a different treatment. And there are a number of non-neuroleptic drugs that, when added to neuroleptics, have been reported, and most of us have had the experience, to change the course of the patient for the better. Lithium is perhaps the one most widely chosen and most widely reported, but carbamazepine, lithium's alter ego, if you will, has also been reported to be similarly effective. So that many clinicians now add these drugs to neuroleptics when a patient hasn't responded. The experience with clonidine has been very sparse, and I am not too confident that it's real. The experience with propranolol after 17 years is that we simply do not know whether this drug, even in the large doses initially used, as an effective treatment for schizophrenia, but in many parts of the world it's used as an adjunct to neuroleptics in treating patients, and there have been reports of patients who had not responded previously who responded when given doses of several hundred milligrams a day of that. In the early 1960s, we treated schizophrenics with 120 milligrams, or doses up to 120 milligrams a day of diazepam. And although we saw some improvement in their behavior, we saw no evidence of a specific antipsychotic effect. More recently, there have been studies using up to 400 milligrams a day that claim to get much better results. I have been very skeptical of those. Right now, the current benzodiazepine is favored as clonazepam, which is simply a very highly sedative drug, and I think it may be just producing more sedation and making the psychosis less evident. However, there may be some use of using these benzodiazepines as adjunctive treatment where the patient has a behavioral disturbance and where the benzodiazepine will curb it as well as probably the neuroleptic, so that you can get by with using less neuroleptic. But as far as bringing patients out of the woods that haven't responded, I'm not too keen about it. At the moment, I mentioned a drug that has the twin indications of being useful for treatment-resistant patients and those with tardive dyskinesia. This is a drug called clozapine, which I assume may be on the market in a limited, very limited use category within the next several months. Clozapine has a rather remarkable history. Sandoz company inherited it in 1970 when they did a takeover of another drug company in Switzerland. They got 3 drugs, one of which was loxapine, which they never bothered to develop, but they farmed that out to other people. Second was metiapine, which didn't go anywhere. And the third one was clozapine, which most of us at that time advised them to pursue, because this was a truly atypical neuroleptic. It differed remarkably from the effects of the other drug. However, by 1975, in the summer of 1975, this drug produced the greatest epidemic of drug-induced agranulocytosis in medical history. Within a span of 3 months, in a small country like Finland with only 6 or 7 million people, there were 15 or 17 cases of agranulocytosis, about a quarter of them fatal, and this curbed enthusiasm tremendously. For a while, it looked like the drug was dead, but later on, it appeared that the experience in other countries was vastly different. That, of course, the drug did produce agranulocytosis, but not nearly that frequently, and it was then used under very restricted use in hospitals only. But as time went on and we became more and more discouraged with what we could do with our present crops of drugs, it began to look better and better. So that recently there's been a revival, and oddly enough, in a study that seems to be relatively impeccable in design, not only was what they did was essentially treat patients with 60 milligrams of haloperidol a day for 6 weeks, and found that the group of patients they selected as treatment resistant did nothing on these doses of haloperidol. Then they randomized them to either chlorpromazine or clozapine in what are construed to be equivalent doses, that is clozapine about 1/2 the chlorpromazine dose, and to placebo, and found that the placebos again did nothing, but and chlorpromazine didn't do very much, but clozapine was markedly superior to chlorpromazine. The first time I think that anybody's ever proven that one of these drugs is better than the other. So this will be an interesting drug to watch. The only hitch is that it produces agranulocytosis, and right now the figures are about 1 to 2% of patients. In terms of the patients in this study, about 30% were thought to have attained clinically important improvement. That is, not just a change on the rating scale that turns up to be statistically significant, but a change based more categorically on significant, clinically important improvement. So you have a 30% chance of getting better with this drug, about a 2% chance at the outside of developing agranulocytosis. And that's going to be the tough choice that people are going to have to make if they wish to go this route. So this is the way you approach these patients. It's nothing terribly new, nothing terribly convincing that we have a chance to salvage a great many of these patients, but at least we may be able to get some of them out of the wood. And what it still emphasizes the tremendous lack we have in our ability to develop more effective treatments than we presently have. And I think this is a primary challenge now to see if we can get out of this circular trap that we've been in for 30 years, where we know pretty much what antipsychotic drugs do. We know how to screen new chemicals to find chemicals that do the same things that antipsychotic drugs do. And we produce new chemicals, but essentially old drugs. That is because their mechanism of action is pretty much the same. Well, I have deliberately tried to be fairly short so we can have a fair amount of discussion, and I'd be willing to entertain any questions from the floor. I may have some trouble hearing, Jim, if I look at you quizzically. Would you repeat the question for me?
Questions or discussion? The question has to do with the use of the same drugs for children as adults.
What else? You don't have much choice. If you have a psychotic child, you've got to make a choice among these various drugs. I know there's a great deal of controversy about the use of drugs of this type in children. There are many child psychiatrists that are dead set against it. Think that the chances of getting tardive dyskinesia are vastly greater in children than they are in other populations, although there's been so little experience with it that I don't know really how one can come to this conclusion. Feel that perhaps the drugs may dampen any efforts at rehabilitation or even plain old education of the children. But I'll tell you, when you get some of these youngsters who are tearing the place apart and who are very difficult to manage, most of them will eat their words and use them. The difficulty is that it has been exceedingly more difficult to prove their efficacy in children. And as I say, that's why there's so much controversy about their use. But if you decide to use the drug for treating a psychotic youngster, then you have to make a choice among one of these agents. And I think that the choice would be made largely on the basis that we do in adults as to which one would be most tolerated by the youngster and which one would be less likely to produce side effects. Now, the high-potency drugs are more likely to produce the acute dystonic reactions, where they get the spastic torticollis type of reaction, whereas the low-potency drugs may avoid that to some extent. So, but it's essentially the same problem. Dopa should make schizophrenics worse.
Another question back here.
Wait a minute.
I'm sorry, we can't hear your question.
I said, do you anticipate any major breakthroughs on the drug in the next 2 years?
Question has to do with any possible breakthroughs in the next 2 years with the drug treatment.
Not that I can tell. I try to keep my ears to the ground and find out what's going on in the field. There are a lot of different drugs tested around the world, and some of them just don't seem to pan out. One that worked through an entirely different mechanism looked to be somewhat interesting, but it developed intolerable side effects. Another one that Burroughs Wellcome had in this country did eventually get a generic name, but most people knew it as BW235 or 234U. Looked like it worked through a different mechanism, but eventually the company came to the conclusion that while it might have had a modest antipsychotic effect, it wasn't as good as the drugs we now have. So that one died on the vine. An attempt was made to tame clozapine by making another homologue called fluparylapine, which has a minor structural difference, but this drug too produced agranulocytosis and bit the dust, simply because if it's going to have the same risk as clozapine, why bother to develop a new one when you've got one that you've got a fair amount of information about already. So there really isn't anything I'm aware of that would be construed as a major new departure in our mechanisms of treating these patients.
Do you find, or do you know, or have any comment about the Mental Patients Association, Clients Associations that are against all therapeutic or drug implementation in their care? They believe they're schizophrenic, but they're independent self-help groups.
The question has to do with groups that may be opposed to drug treatment of schizophrenics. Would you have any comment on that?
Well, what are you going to do?
Do you feel they're really, even though they might be classed as schizophrenic, might be that they may not be schizophrenic? These people say they have been healed of schizophrenia. Do you think they can be if they really have it?
I think she's raising the question about the issue of is it the correct diagnosis?
Yeah. Well, obviously, the best results you get in schizophrenics are treating patients who don't have it. then you usually get a pretty good result. But, there have been so many efforts done to try to manage schizophrenics by various kinds of psychotherapy. If you're R.D. Lang, you take them in and live with them, and then you become them, and they become you, and you can't tell the difference. I remember we used to have Gregory Bateson at our hospital who thought it was all a matter of communication. And well, I had a little patient, Gregory was about this tall, and I had a little patient about that tall who had the most beautiful word salad you ever saw. He couldn't write two words together that made any sense. So I tipped Gregory off and I said, here's the guy that's got the Rosetta Stone of schizophrenic communication, if you can interpret it. Well, Gregory lived with this guy for months. They see him around the campus. Of course, Schmitty, the little guy, was sort of deteriorated and always looked sort of sloppy. And Gregory was a typical English academic who also looked sort of sloppy. And I think over the months, Schmitty improved a little because we were giving him an antipsychotic drug, and Gregory got a little worse. Again, this regression to the mean, and he never did uncover the Rosetta Stone. So I think that you really have to be realistic that in terms of what you can achieve with treating schizophrenia, there's really not much else that has a demonstrably specific action than drugs. Now, once you get a patient into some sort of remission, then if you manage them as you would anybody else with a handicap, and try to find ways to rehabilitate them around their handicap, that makes perfectly good sense. But to try to give them insight is nonsense. As one of my friends said, you're trying to add insight to injury. You know, it just doesn't make any sense. Now, oddly enough, with the development of these AMIs, the Association for Mentally Ill, which are largely families of people who have schizophrenia, we're getting tremendous support for our approaches to pharmacological treatment. These people have lived on the front lines. They know what it is to have a schizophrenic family member, and they know what even what limited effects drugs may have are certainly beneficial for their patients, and they have been one of our greatest support groups. I don't know why it took us so long to bring them in the fold, but they are now very strong allies.
Does ECT have any place in breaking an impasse?
What is the role of ECT in the treatment of schizophrenia?
Yeah, I guess it was used in the old days primarily for very excited patients that seemed to have some way to cool them off. But these days, you can do that so many other ways that are much simpler that that indication doesn't hold. I don't think ECT ever really had clearly demonstrable benefit in terms of ameliorating the psychosis. It's quite a different situation in the depressed patient, but as far as schizophrenia is concerned, I don't think anybody currently would think of it as being indicated.
Your comments on neuroleptic malignant syndrome.
Neuroleptic malignant syndrome is a relatively uncommon side effect of neuroleptics. I think the best way to think of it is simply as a markedly accentuated Parkinson's syndrome. The patients first get very stiff, and they get so stiff and shaky that they generate a tremendous amount of muscular activity. As long as they can sweat, they don't develop fever, which is always thought to be one of the diagnostic triad. You don't have to have fever to have neuroleptic malignant syndrome if you have a physiological way of dissipating your heat. But when they lose enough fluid or whatever that they cannot sweat adequately, then they develop hyperpyrexia. In addition, they develop a number of evidences of autonomic instability, such as rapid heart rate, elevated blood pressure, and so on, which I think are just mainly reflective of the tremendous amount of work that they're doing, physical work. These people are working. And but also possibly due to some midbrain loss of control of autonomic function. So the three diagnostic criteria are marked rigidity, hyperpyrexia, it may be, and autonomic instability. A few patients have died, I guess, essentially of the effects of what might be construed as heat stroke when they get the body temperatures up to 42 degrees centigrade or 106, 7, 8 Fahrenheit. But most of the time it should be successfully managed. There are several ways you can manage it. The belief is that it's due to a sudden blockade of dopamine receptors, so you can work on the dopamine pathways in the brain by giving a dopamine agonist like bromocriptine, Parladel, or you can work peripherally by giving muscle relaxants that will relax the muscular activity so they don't generate so much heat, and baclofen or diazepam, a number of other, I can't think of it. No, I mislaid the drug that may be useful as a muscle relaxant. So there are two ways to approach it, one centrally, one peripherally.
In Europe, they've reported good success with the drug Clomipramine in severe obsessive-compulsive illness. Are you aware of any research with that drug overseas with schizoaffectives or schizophrenics?
No, clomipramine is simply a chlorinated homologue of imipramine, and most of us can't explain why it should be so different qualitatively from imipramine itself. You know, if you have a chlorinated homologue of promazine, you get chlorpromazine, which is more potent and probably a more specific antipsychotic drug than promazine was. But I simply don't know why clomipramine should be so much different. There's been some arguments. Some people say, well, you're really treating the depression that many of these obsessive compulsives have, but I would doubt that that's the whole explanation. And of course, obsessive compulsive disorder is a tremendously difficult disorder to treat by any means. For one reason or another, the drug is not going to be introduced into the United States. I think the reasons are pretty clear. It's just not economically feasible. It costs you several $million to get a drug through the FDA, and how many obsessive compulsives are there out there? The company doesn't see enough sales to get back their investment. It is available, however, in Canada and I think also in Mexico. So for a while I had people traipsing up to Canada or getting a friend up there to get a prescription written and get it filled and then send it down here. But I think in the last year or two, Ciba Geigy, who has this compound, will give it to people on what's called a compassionate IND. And that means you go to your Ciba Geigy representative and tell him you've got a patient you've tried everything on who's obsessive compulsive, you'd like to try this, and then they send you a booklet about that thick to fill out and keep data, and they'll give you the drug. But they have to do that. They have to make it a kind of experimental procedure. But if you're willing to do that, you can get access to it.
Again, going back to the neuroleptic malignant syndrome, what do we do? How do we treat the psychosis should they develop neuroleptic syndrome?
Yeah, that's when you have a neuroleptic malignant syndrome, of course, obviously the first thing you do is you stop the drug. Then what do you do for an encore? Because the patient will still be psychotic and presumably require more drug. Well, the effects of retreatment have been somewhat controversial in the literature, but if the concept is correct that it is the rate of change in dopamine receptor function that is critical, then clearly if you can slow this rate down, you may get by with retreating the patient either with the same drug or something different. And there have been many examples of this being done. So if the patient really needs the drug, I would go ahead and give it to them, but be very, very conservative the second time around and build up doses from very low levels very slowly. Very often, neuroleptic malignant syndrome will occur after the first dose of the drug, especially if it's a good-sized wallop given intramuscularly, again supporting the notion that it is the suddenness of the change that is important. So if you want to retreat, you have to start off very, very gradually.
Way at the back.
Could you tell us your thoughts on the appropriateness of using the decanoid injections on admitting wards or for inpatients in general?
The long-lived depot preparations have an interesting history. This notion, which is essentially a very simple one chemically, but it's one of those ideas that's so simple you say, why didn't I think about it, is that if you have a drug that has an alcohol moiety on it, that's a CH2OH, you can make an ester with a fatty acid and create essentially a new molecule. Now somebody at Squibb, I think way back in the 1950s, doped this out. And for a long while, Squibb did this with a variety of hormones, cortisone, estrogen, progesterone, testosterone, and their trade name was DELA, delay, for the prolonged action, hyphen whatever the hormone was. But mostly this was only known to endocrinologists. However, just by chance, prolixin happens to have the necessary alcohol moiety, and they put it out in the original form of an enanthate. That is a 7-carbon fatty acid. But by that time, the patent was running out not only on Prolixin, but also on the enanthate preparations. And with great cunning, they shifted to a 10-carbon fatty acid, the decanoate. And oddly enough, this gives you another 17 years. So now, as far as we know, the length of the carbon of the fatty acid has nothing to do with it, because the cleavage is at the ester bond. That is, the whole fatty acid comes off all at once. It's not like the metabolism of fatty acid where you're chopping off 2 carbons at a time. This is the whole smear. So it's very hard to see that there was really any difference between the enanthate or the decanoate, other than the fact that the decanoate gave a longer life to the drug. But it is a cute idea, and there's no question that it does cause a slow release. The release characteristics of these preparations I'm not too happy with yet. We're doing currently a study on that, but because it's somewhat variable, but it's still, for maintenance treatment in a patient who is unreliable about taking oral medication, it certainly has much to offer. As far as using it in inpatients is concerned, I'm not so sure. In our present study, we are trying that. That is, we are giving a big wallop of haloperidol decanoate, doing our measurements on the release characteristics, but hoping that this big wallop will control our patients over the next 3 weeks or so while we measure these blood levels. And so far, with our limited experience, I think we've only had 3 patients on the protocol. They've been pretty tough to manage this way. So I don't think it's a suitable thing for titrating the dose of drug for a patient, because there you want to have very rapid feedback. And if you have to give any parenteral dosage form, I would give a hydrochloride, say flufenazine hydrochloride, where you get immediate input and you know where you stand and so on, and get control of the patient. But for maintenance treatment, I think it certainly makes a lot of sense.
Would you give us an up-to-date on the determining drugs that are mainly using in Europe for the treatment of negative schizophrenia, the negative symptoms of schizophrenia?
Oh, the negative symptom. Well, all of a sudden these became very popular, big issue. I don't know of any drug that's specific for negative symptoms, but I think there's been an artificial dichotomy created by talking about negative symptoms and positive symptoms in the sense that they're either one or the other. Schizophrenics have both. I looked over our data from studying several hundred newly admitted schizophrenics, and on the brief psychiatric rating scale, you can tease out certain items that give you kind of a negative symptom score. And while the score that these patients had on negative symptoms was somewhat less than they did on the positive symptoms, the changes were proportionate. That is, when you treat them with an effective antipsychotic drug, those kinds of symptoms improve. So I think there's been a kind of mythology built up as if, some patients are all negative and some are all positive, and this just isn't the real world, or that, the drugs only move the positive symptoms and don't move the negative symptoms, which is certainly not anybody's experience. Nonetheless, the negative symptoms do seem to be harder to move. And I think in the old days we used to talk about burned out schizophrenics who had lost most of their positive symptoms. They weren't talking to the voices or acting up anymore, but they were kind of socially withdrawn, apathetic, unmotivated people who were lingering around the state hospitals and looked for all the world like the description that was given them, burned out. They didn't have an active psychosis, but they still had this impediment to normal function that was considerable. Now, if we could have something that would work for this would be great. Some people say, well, those patients may have really a hypodopaminergic state and should be treated with drugs that increase dopamine activity, such as amphetamines. Well, sure, amphetamines will goose up a person who's indolent, but it'll also make you crazier. So you pay your money and you take your choice. You can't use amphetamines very much in these people because you're going to make their psychosis worse rather than better. One of my bright young fellows made the observation that high doses of alprazolam seemed to work in these patients. And we treated about 8 such patients, found 5 of them looked like they improved, and sent out a preliminary report. And then again, I warn you against trying to replicate. we designed a nice controlled study with diazepam, alprazolam, and placebo, and we found no way. This didn't work.
What about surgery, fluoridone, limousine?
I didn't hear that.
I don't think we can hear that. Would you try again?
Well, in Europe it's being used fluoridone and limousine, which is being used here now on Tourette syndrome, surgery.
Would you come up and use the
Yeah,
microphone?
come on up. We've got some noise up here from the ventilating system that sort of obscures.
Thank you.
Yes, could you give us an up-to-date regarding the diphenylbutyrpiperidines that are being used in Europe that I understand are also to some degree calcium channel blockers and also dopamine antagonists, dopamine blockers?
Well, the dopamine antagonists are the drugs we've been talking about. That is, by blocking dopamine receptors, they could be construed as dopamine antagonists. As far as neuropeptides are concerned, there's been a great deal of interest in these things because they are in the brain, but nobody knows for the life of them what most of them are there for. Now, the first neuropeptide to be recommended in schizophrenia was thyrotropin-releasing hormone, which is a tripeptide. That is, there's only 3 amino acids, and so it's possible with a molecule that small to give it orally, and although 90% of it is degraded, you still get some into the circulation and into the brain. The first reports on thyrotropin-releasing hormone claimed that it was useful in treating depression. We tried it and found no evidence at all. But before we could even complete that study, a report came out, incredibly enough, that it was also useful for treating schizophrenia. We tried it in that situation, and after we treated 5 patients, we had to stop because the nurses on the ward said, you can't go on with this, the patients are getting so much worse. And indeed they were. We had one patient I remember very well because I interviewed him, came in, and he had such a marginal evidence of psychosis, and he talked so dispassionately about the voices he was hearing that I began to wonder whether he might be a ringer. You know, at that time at Stanford, we had a psychology professor who would go on wards of mental hospitals and play like he was a patient, be taking notes all the time, and nobody ever asked him what he was writing. So he exposed us all for being frauds. I was afraid I was going to be taken again by one of these guys. But I said, well, go ahead and treat him anyway. And by golly, after a few days on TRH, he was so psychotic it was unmistakable. He couldn't even complete a sentence. He was blocking right and left and so on. So that it very definitely makes schizophrenics worse. You're always puzzled about drugs that make schizophrenics worse as well as better because they may give you some clues. It now appears that some metabolite of this tripeptide may have dopaminergic activity in its own right. Well, since then there was a lot of furor about endorphins and naloxone. I think I can summarize it in a nutshell, nothing to it. There were initial reports, but I don't think any of them have been sustained by the confirmatory studies. I think that issue is dead. More recently, there's been some great deal of interest in cholecystokinin homologs. That's an 8 amino acid peptide. Probably doesn't get into the brain. Once you get above 3 or 4 amino acids, it's very hard to get into the brain. But the biggest study was one done in Japan with 140 some patients, and they used one of the cholecystokinin homologs and found nothing to it. And I think that's a growing consensus. So at the moment, there is nothing on the neuropeptide scene that looks to be at all encouraging. But we'll hear more about it because there are a lot of neuropeptides in the brain, and they must be there for some reason or other. So probably all of them will be tried.
We are running out of time. I'd like to thank Dr. Hollister for sharing his very specialized experience and knowledge in this important area. And I'd also like to, before we quit, thank Squibb Pharmaceuticals for helping us bring Dr. Hollister for this presentation. Thank you.